Onc Live Insights is a video editorial program produced by Onc Live.
My approach to a patient with newly diagnosed follicular lymphoma is first to assess if they have symptoms. Some patients with follicular lymphoma are actually asymptomatic. They have just discovered a lump in the shower or wherever, and that's what brings them to medical attention. So when a patient comes in with a new diagnosis of follicular lymphoma, they may not be symptomatic. And those patients may be a candidate for a watch and wait strategy. In other words, they don't automatically need treatment right away. Before we make that determination of whether treatment should start immediately or can be deferred, we assess their tumor burden. That requires imaging, either CAT scans or more commonly nowadays a PET scan. And so some patients will be asymptomatic and have a low tumor burden, and there are criteria for this. And those are the patients who are a candidate for a watch and wait strategy. And they can be observed sometimes for years before treatment needs to be initiated. That's a very commonly used strategy around the world. Some patients will be asymptomatic but have a high tumor burden. You do the imaging, they have very large masses, or you see lymph nodes in parts of their bodies that look like it could cause a problem in the relatively near future. Those patients should be started on treatment. Or if a patient has symptoms, if they come in the door and they feel poorly, there are many good treatments that can make them feel better. So those patients will start on therapy. So then the question is, what therapy? What therapy is most appropriate for these types of patients? Typically, my first-line treatment approach is to give a combination of bendamustine and rituximab. It's a very well-tolerated regimen for most patients. You can use that regimen in patients easily into their 70s and sometimes 80s. You may need to do dose reductions of the bendamustine if the patient's older or if they have a reduced creatinine clearance, but by and large, patients tolerate this regimen quite well. No hair loss, so they don't even look like a cancer patient when they're going through this treatment, which patients like. And then when that treatment is finished, we typically recommend 2 years of maintenance rituximab therapy, a single dose every 2 months for a total of 2 years or 12 doses. I will emphasize, however, that the maintenance part is optional. Maintenance therapy prolongs the remission duration or progression-free survival, but hasn't really been shown to have an impact on overall survival yet. And for that reason, I have a conversation with the patients about maintenance and what it'll do for them and what it won't do for them. It'll take the remission you are now in and it will make it last longer. On the other hand, if we do the maintenance, it doesn't appear likely to make you live longer ultimately. What's the downside to the maintenance? Well, you got to come and see us here in the hospital every 2 months for the next 2 years and sit in an infusion room and have the drug dripped in, and not everybody wants that. And so I would say for every 10 patients that I present the maintenance option to, probably 7 or 8 of them will say, I'd like to do the maintenance, but maybe 2 or 3 will say, I'd rather not do it, and I'm fine with either strategy.
What's going to be important is to see long-term whether or not there's a difference in these regimens in terms of inducing secondary MDS and AML or even transformation. With follicular lymphoma, of course, the development of resistant disease is certainly problematic, but the transformation from a low-grade follicular lymphoma to an aggressive lymphoma is also very problematic. So seeing how these two populations of patients compare long-term will be important. The ultimate question is if there's an advantage to maximally debulking our patients, where if we can reduce the amount of disease to as low as possible is the best way to actually avoid future transformation, or if it's better to sort of minimize the chemotherapy exposure, with the chemotherapy being the source of the DNA damage and the secondary changes that often give rise to our transformations. And so those are data that we hope will get long term. With that in mind, these new regimens that are avoiding chemotherapy for for patients who are previously untreated, I think are very interesting and important to examine. One of the combinations that I'm most excited about for patients with follicular lymphoma is lenalidomide or Revlimid plus rituximab. This regimen, also known as R squared for Revlimid and rituximab, really affords a great opportunity to treat patients very effectively for very long periods of time without toxicity. And the hope, of course, is that being able to maintain a patient on a therapy like lenalidomide and rituximab that will control the disease long term will really be able to push the median progression-free survival very far out. And certainly if a patient progresses on Revlimid and rituximab, there's the opportunity to treat them at that point in time with chemotherapy, as it's really not clear that these treatments with these non-chemotherapeutic agents really set people up to be resistant to chemotherapy subsequently. So any time gained early on in terms of delaying the chemotherapy is time gained for by the patient.
R squared has looked very promising when tested in patients with relapsed follicular lymphoma, and now there's published data using the regimen in frontline follicular lymphoma, and the results are really outstanding, and that has led to the design of a large international trial called the Relevance. And the Relevance trial is ongoing, being done in centers in Europe and in the United States. And it's either completely enrolled or nearly completely enrolled at this point, and we're all anxiously awaiting these results. And there's a chance that this R squared regimen could supplant rituximab and chemotherapy as the standard for frontline follicular lymphoma therapy. Although I will caution folks that the bar is very high. Rituximab and CHOP or bendamustine and rituximab are very, very effective treatments in follicular lymphoma, and it's no small task for R squared to knock what we currently give off the top of the mountain. So I wouldn't be totally surprised if our chemo maintains its position, but it's something we're all very interested in to see if a chemotherapy-free approach could be as efficacious as a chemotherapy-based approach.